Hello, everyone. Welcome to today's live broadcast. Proenkephalin, a novel new biomarker for assessment of kidney function, early prediction, and identification of acute kidney injury. I am Robert Castellanos of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by Surrogate. Surrogate develops innovative biomarkers for diagnosis, prediction, and monitoring of acute medical conditions such as acute heart failure, acute kidney injury, and circulatory shock in order to support patient management and provide guidance for treatment strategies. Furthermore, Surrogate develops biomarkers for prediction of health risks such as obesity, cardiovascular diseases, breast cancer in order to support prevention strategies. For more information, please visit surrogate.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the C button located in the bottom left-hand corner of your webpage and follow the process of obtaining your credits. Another way to interact in today's webinar is by taking a few moments and answering poll questions that are being pushed out to you, the audience, right now. There will be another chance to interact with these poll questions at the end of our presentation, right before a question and answer section. I would like to introduce today's speaker, Dr. Alan Maisel. Dr. Alan Maisel graduated from the University of Michigan Medical School, received his international medicine training at Michael Reese Hospital in Chicago, and completed a cardiology fellowship at the University of California, San Diego. Dr. Maisel is a professor of medicine at the University of California, San Diego, UCSD. He is the director of the Coronary Care Unit and Heart Failure Program at the VA San Diego Healthcare System in La Jolla, California. Dr. Maisel is an active on the faculty at UCSD, where he has won numerous teaching awards. He has just finished a 10-year stint as associate editor of the Journal of the American College of Cardiology. He is considered one of the world's experts on cardiac biomarkers and has over 300 scientific publications. He has authored several groundbreaking publications that have paved the way for the development of diagnostic tools for patients with congestive heart failure. In particular, he was the leading investigator on studies that brought the use of BNP into clinical practice. I will now hand it over to the doctor for his presentation.
Okay, thank you very much for that kind introduction. And I am Dr. Alan Maisel, and I'd like to thank each of the attendees for taking a little bit of time out of their day to listen to what I have to say about this very interesting biomarker, Proenkephalin. And please ask questions at the end, and hopefully we'll have time to answer each and every one. So, I'm going to start out by just mentioning how important it is to be able to diagnose early kidney injury, especially in critically ill patients. And this is an unmet need, and it's a big one. AKI, acute kidney injury, is a frequent complication. About 30% of everybody in the ICU, 50% of people with septic shock. And in those patients where you get AKI and septic shock, there's a mortality rate of 50%. Hence, it behooves us, if we have any chance of helping that patient, to make the early and accurate diagnosis. Now, here's just a chart that depicts in the red there all hospitalizations, and the blue bars are the prevalence or incidence of kidney injury or acute renal failure. And you can see that more and more kidney injury is occurring in hospitalized patients. This slide demonstrates the percentage of where these kidney injuries occur. And about half, or a little more than half, occur right in the hospital. About 35% in primary care and about 12 or 13% during outpatient procedures. Now, when we talk about biomarker testing in general, and I'll use heart disease as an example to start with because this can serve as a good introduction to how to look at kidney biomarkers. In heart disease, we would use a biomarker for diagnosis, for risk stratification and screening, and if we are lucky, to monitor and then to offer therapeutic guidance. In other words, you have a condition, as you see on the right, that has a certain outcome. Can we find a pathophysiologically relevant biomarker that will lead us to an intervention that can change that outcome? That's what we want to use biomarkers for. And in heart failure, it's fairly straightforward. There are 3 that I measure right now in my heart failure patients that all have relevant pathophysiologic mechanisms, whether they be mechanical stress, ischemia, volume overload, fibrosis, that lead to disease activity. All these biomarkers can move and be affected by treatment, and they're very important surrogates that we can use. And as I've been speaking and going to the renal meetings, I would ask, well, where are the biomarkers for the kidney injury? And, I point out to what we have had, say, in acute myocardial infarction, but over the years, if you compare, we really have not had anything except the serum creatinine, which, as most of us know, is not an early marker. The promise for biomarkers for kidney injury would be like the promise of the high-sensitivity troponin with a cardiologist. We want a nephrology troponin, if you will, to be measured somewhere that will lead us to early management and perhaps development of new therapeutic strategies, even if we don't have any right now. In part, it is because we haven't had an early signal to treat early. And I think once we have that, new therapeutic strategies will in fact be studied and we will find some good ones. Now, let's just go over a few important considerations for renal assessment with biomarkers. The protein or hormone should be a reflection of renal function. And this renal function should be real time, not past renal function like we would see with cystatin C or creatinine. It should be analytically validated for accuracy and precision in the clinical study. The results should be easily interpreted in the study. Is there a cutoff below which you're safe, above which you have risk? And does this test have clinical value? Well, you see these are a bunch of the biomarkers that are either for research or clinically available, but most of the present day, take a look at creatinine. Look at the simple matrix, the inflammation, the specificity, and the dynamic status. And as you go down the line, starting with creatinine, we see there's really at least an unmet need that we still need to fulfill. And that's where Proenkephalin comes in, a new biomarker of renal dysfunction. Now, Proenkephalin is new, but Enkephalin is not. We all learned about Enkephalin in med school because it's linked to many opioid receptors, but it was always almost impossible to make the right assay to study it in real time. We've learned about the CNS-derived enkephalins, which are sort of the natural painkillers, but the non-CNS enkephalins are actually released mainly by the kidney and then the heart. The receptors released by the kidney and then the heart. So renal, and then probably, as I'm a heart failure doctor, cardiorenal. These ligands are the 2 different opioid receptors, and they're very abundant in the kidney. So we think that proenkephalin is a biomarker that is a surrogate marker for enkephalin. It's a pro-neurohormone. It was invented by the same group over initially at Thermo Fisher, but now at Singotech, that invented other proneural hormones that are an important part of our practice, such as procalcitonin. This marker is special, and instead Proenkephalin is a long name, so we call this Proenkephalin PenKid for the kidney. This is a great surrogate marker, as I'm going to show you. It's inflammation independent, and that separates it apart from any other blood marker that I know. It also, because of the stimulation and the interaction with opioid receptors, it indicates an actual need for kidney stimulation and subsequent renal excretion. So it's a very active marker functionally. So here is what PenKid measures. It's a stable component of the precursor. It is the, you can see it's a 119 to 159 pulled out of there. It's very stable versus the unstable enkephalin peptides. So stable this can easily be used for routine clinical testing with a very good assay, and around the 99th percentile, you have coefficient of variations, you have precisions, you have 10%. Well, one of the reasons I like it is shown here in this slide. First of all, I've looked at many biomarkers of kidney injury, and many may show some link to injury but don't really correlate to kidney dysfunction. These two slides, taken from two different studies, demonstrates both a strong correlation with serum creatinine and an inverse correlation with estimated GFR. I think this is very, very important. Now, to show you the renal specificity here, how it's corroborated with the PenKid assay, this is from Dr. Eng, looking at over 1,000 patients after an MI. And in this one table taken from the manuscript, it shows overall PenKid levels reflected renal status better than anything. And there's a 10-fold difference in concordance of GFR versus other predictors of PenK. PenKid levels were the highest upon presentation and very likely a reflection of the overall cardiorenal status. And in fact, the reclassification index for those graded as low risk but had ventral complication was 18 using the PenKid. So it's not giving you just diagnostic, but it's giving you great risk stratification right off the bat. Now, as a heart failure doctor, this is one of the reasons I'm really interested in PenK, because if you look in these two graphs, and I'm going to go back to this, but we're going to use a cut point here of 100 picomole per liter. This appears to be one you can take home to the bank. You can use this today in your clinical practice. This shows the prediction and the diagnosis of AKI in people with sepsis and heart failure, days before the creatinine goes up. But also, even more important for me, is prediction on the right box of recovery. Because when my heart failure patients get kidney injury, that creatinine may take 5 or 6 days to come down. I need to keep them in the hospital till it starts to come down. If the PenK drops 3 days earlier, that's 3 days earlier, I can send them home. So PenKid is really predictive of the onset and the offset of kidney injury. So let's look at the clinical validation of PenKid in clinical populations here. First of all, you should understand this, because if you think this is a new kid on the block and it needs more studies, well, think again. There are more studies coming, but right now it has broad validation. There has been 25,000 patients in 18 countries, over 600 study centers where this has already been looked at. I think this is more patients, I would guess, than even was looked at early on with B-type natriuretic peptide measurements. Let's start with cardiac surgery, because we did this right at my hospital, as a matter of fact. I sent some of my young students who wanted to get experience into the OR at 5 o'clock in the morning to consent and collect samples and then get them post-op 2, 6, 12, 24, and 48. We found that in those patients who developed associated AKI, that PenKid was elevated within 6 hours. Creatinine only after 2 days. This is clinically, I think, very important, especially in the early post-op setting, which rise in PenKid could certainly trigger close attention to pulmonary wedge pressure readings, to what we do with fluids and inotropes, and also nephrotoxic potential for antibiotics, contrast, etc. So that's cabbage. Let's look at other critically ill patients. Let's start in sepsis, right in the emergency department. Now, this took place in the hospital of my dear friend and colleague, one of the leaders in biomarkers, Dr. DeSoma, who looked at 100 patients, consecutive patients who came in the ED, and they diagnosed sepsis. They were enrolled within 12 hours and had daily blood draws, and then they define here AKI by the rifle criteria. So here, these two figures will demonstrate, number one, that PenKid is independent from inflammation, and two, predicts AKI severity and mortality. Notice that PenKid levels are in the normal range if you have no kidney injury or if you're just at risk. Risk is the R for rifle. You look at almost any other biomarker in the blood, and in sepsis, which has to do with inflammation, those levels will be high with no risk or in the R group. So this alone sets PenKid levels apart. They are high when you have kidney injury, and the more you have, the higher they are in these septic patients. If you don't have it, it's not up. It's not reflected by inflammation. On the right side, you can see survivors and those that are dead within 7 days versus PenKid levels. Again, looking at that cut point, maybe a magic cut point of 100 picomole per liter. Admission, PenK can predict mortality. But admission PenKid levels is not the only story. PenKid is a highly dynamic biomarker. This is why I like it. I want a biomarker that will tell me they're at risk, tell me they have injury, and I can do something and then see what happens. And I know if it gets better, they're going to get better, and if it doesn't, well, I better try something else. Here's 4 patients. Patient 1, the whole hospitalization had higher than the normal range and died. Patient 2 had very high levels, 600, but toward the end of the hospitalization, it went down. They survived. Patient 3 started in the normal range, but within several hours, 12, went up and up and up, and they died. Patient 4, throughout the whole septic course, stayed low, and they died. I mean, they lived. So stayed low, they lived, high, you die. Now, this next slide will show that as you measure serial PenKid levels, you can actually see the changing risk of mortality by indicating kidney function. On the left side, you can see the survivor rate and the time at a cutoff of 100 based on whether you had low PenKid or high PenKid. Now, if you look at the subgroup that had high PenKid and then measured it 4 days later, if it was still high, 50% died. If that PenKid went to below 100, they all survived. This is very important, and I think if you're a physician, you can see right now how this could help you. Even if we don't know what to treat with, although I have some ideas, we know by risk stratification that they are now in a low-risk group. Maybe they can go out of the ICU to a step-down unit. There's a whole host of interventions we could think about. The therapeutic goal, in other words, in sepsis, is to try to normalize the PenKid levels. This slide demonstrates that if they're normal, you are alive, and if they're not, you have a good likelihood of dying. Do we know all the treatments that can lower PenKid? No, we don't. But as I said in that famous movie, Field of Dreams, build the field and they will come. Find an early marker that's associated with diagnosis so you can get therapy started, and therapeutic companies will jump to the table with interventions targeting PenKid levels. Here's another sepsis study, and again, this is 42 consecutive ICU patients with major surgery and signs of sepsis, median age of 70, 6 days in the ICU, 18 days in the hospital, and this is renal dysfunction with acute decrease in urinary output for at least 2 hours despite fluid resuscitation. And again, renal dysfunction and PenKid levels, you can see that when there's no renal dysfunction, PenKid is in that normal range, and it's quite high if there is. Let's not stop there. There are a multitude of studies here. Some of these have been presented in small papers and abstracts, but believe me, the literature is about to be inundated with these large studies. Take this one out of France, the FROG ICU study, over 2,000 patients in the ICU, sepsis and non-sepsis. This was an observational study in an ICU patients who either required mechanical ventilation or vasopressors or inotropes for over 24 hours during their stay. You can see the demographics on the left side. These were sick patients. On the right side, you can see AKI severity by the rifle criteria, PenKid levels. Once again, the PenKid levels are not elevated until you get injury. Other biomarkers of kidney injury do not have this specificity when inflammation is present. And in sepsis, there's almost always inflammation, so very few biomarkers will be good to use in this setting. PenKid is one that can be used right now. Here's another study. You've probably heard of this study. It's quite famous. The abstract for the PenKid just been presented. The paper is being formatted. This is the Albio study of albumin giving in sepsis study, and this is an analysis, sub-study analysis. Once again, PenKid was diagnostic for AKI and also predicted both the need for renal replacement therapy as well as 90-day mortality. So sepsis, 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 it's there. This is filling an unmet need right now. But as a cardiologist, of course, I'm interested in other types of cardiac diseases. Here's one by Dr. Eng and his group, published in JACC just in 2014, and the prognosis of PenKid as a kidney dysfunction marker can actually predict mortality in acute myocardial infarction above and below the median levels. If you look at PenKid and the 2-year MACE prediction, you can see the hazard ratio. Univariate was 15.5. The multivariate of PenKid was 5.5-fold risk. It beat the other biomarkers in this. And look at NT-Pro, wasn't even significant in a multivariate analysis. And I think this is because NT-pro is so tied up with clearance issues. But this is one in acute myocardial infarction that is excellent at MACE prediction. Also, if you look at long-term mortality, and this was the PenKid divided into 3 tertiles, you can see the 99th percentile normal here was about 80, but tertile 1, 2 is in our sweet spot of 80 to 129, and tertile 3, you can see a marked correlation in event-free survival and those PenKid levels. So if you really look at the summary of PenKid and the medical utility, here is one way to look at it. If your PenKid on the top there, if it's elevated and your serum creatinine is high, you have AKI. If it's elevated, but your creatinine is still low, you have a high risk of AKI. That means you would certainly want to monitor this, and that means that perhaps for me, in the setting of heart failure, I'm going to be worried. I'm going to be worried in a heart failure patient that looks pretty good, the creatinine's pretty okay, but the PenKid is over 100. Am I really going to send them for contrast CT? Am I really going to start them back on their ACE inhibitor right away? Am I really going to give them high dose of a diuretic early in the emergency room? And the bottom of this shows what a low PenKid means. Low, less than 100. Does it mean that if it's low but the creatinine's still high, that the patient is recovering? Or if the creatinine is low, they have no AKI? Now, I am a biomarker guy, and I actually love the negative predictive value of biomarkers. They're usually even better than the positive predictive value, such as a high-sense troponin can rule out acute myocardial infarction in 100% of people within 2 hours. A BNP of under 100 can rule out acute heart failure in 90 to 95% of patients. If you're in the emergency room, say with heart failure, which is what I like, but even in sepsis, and your PenKid is low and your creatinine, you are good to go. You're not worried about what you start medicine-wise. This is important. On the other hand, in heart failure, 30% of people get kidney injury in the hospital. Most of this is somewhat iatrogenic from all the diuretics we give and the ACE inhibitors and LDL blockade, etc. But once they get kidney injury and you have heart failures, it can take so long to come back. We must keep a patient in the hospital till that creatinine comes down, because we don't know. If it doesn't come down, it means it could have a chance to go up, which means we could send them home and they could come in dead from hyperkalemic cardiac arrest. But when I am able to use PenKid, it will be very likely that as I follow this patient recovery, I will see that PenKid drop 2 to 3 days before the creatinine drops, and I can probably send them home. Now, yes, I will bring them back to double check, but I can probably send them home, and I would say to the family that I think your husband is out of the woods now. The early marker of injury is improving. So some conclusions from our evidence-based discussion today. First, PenKid is a reliable surrogate plasmic marker for enkephalin, which has been around a long time, expressed all over the kidney and the heart, but we could never measure it. PenKid has been clinically validated in thousands of critically ill patients. More patients, I would suggest, than BNP or possibly even troponin before they were approved. there is definitely clinical utility of PenKid, because if you can predict and then diagnose acute kidney injury and diseases like sepsis and heart failure, there's a lot you can do. If you can monitor acute injury for early recognition of normalization, that's a lot you can do, and you can reclassify that patient down to a lower risk, get them home earlier, at least out of a busy, expensive ICU. A very important takeaway point here, ladies and gentlemen, is PenKid is not affected by systemic inflammation. Every other blood biomarker that I can tell that's been studied that rises early also rises because of inflammation. This does not. So in sepsis, bingo. Heart failure sometimes has inflammation as well. Also, other real-life variations that have been looked at in these 20,000 people, we have not seen PenK affected. Other comorbidities, age, sex, other real-life variations. Maybe we'll find some, but we haven't really seen many yet. And finally, if you want to bring a biomarker out into clinical practice, and Lord knows we have made many mistakes in other kidney markers, such as NGAL, that we have brought out in practice without reliable cut points. For heart failure, for sepsis, etc., causing mass confusion, sometimes disbelief, and then finally abandonment. As far as we can tell, in these 20,000 patients, you can put that stamp of 100 picomole per liter for all clinical settings. And to conclude, I want to step back a little bit and talk about how I use biomarkers as a clinician. This is very important. It's a balancing act. It really is the merging of science, of medicine, the guidelines, the data, but also merging with the art of being a doctor. Now, let me go back a second. If I invite you to my house, and by the way, just to plug, April 7th, we have our famous biomarker meeting in San Diego, of which for years we've been talking about this biomarker. And I say that because for faculty, et cetera, that come over, or friends, we have a barbecue by the ocean at my place in San Diego. It's a lovely place. And if you were coming and I would say, what would you like me to barbecue for you? You have a choice of chicken or steak. Well, you would be wise to choose steak. And the reason is there are more ways to grill chicken than steak. I mean, grilled steak than chicken. Look at this for steak. In chicken, it's salmonella, or you could bounce it like a rubber ball. And the analogy is with biomarkers. Having biomarkers around, ladies and gentlemen, trust me, it's more like grilling steak than chicken. It gives you more opportunities. I told you all the opportunities that you can see in sepsis, in heart failure. Some of these need to be tested in randomized studies, and some probably don't. Some don't necessarily need to be in the guidelines, but it makes clinical sense. Why would you start keeping ACE inhibitor going if you saw a high risk of a heart failure patient who needed a lot of diuretics come in with volume overload and a high PenKid level? You need a guideline study for that. You need some brains. And that's why I sort of leave with this. A biomarker can make a bad doctor worse, but will make a good doctor better. What do I mean? You don't use a biomarker by itself. You use it secondary to your clinical judgment. Here's a stupid doctor. Here's an ER doctor in a hospital in Boston reading a New York Times, probably hungover on a Sunday morning, feet up on the table. The intern comes and says, Dr. So-and-so, I have a patient with a high troponin and chest pain. And the doctor looks up and says, well, is it a STEMI? Well, no. and he doesn't go see the patient, doesn't read the EKG, but it says cardiology to see patient for elevated troponin. This is a bad doctor, ladies and gentlemen. We know the specificity issues here. You need to see the patient. There's no substitute in medicine for hands-on, open-ended history and physical exam demonstrating compassion and empathy so that you can make the correct clinical diagnosis. And then you put together the treatment plan, and that biomarker helps with the diagnosis, the risk stratification, and yes, ladies and gentlemen, I think it will help the treatment plans, because at the end of the day, we as physicians are healers. You as even lab people here are healers. You help us get these tests out there. And this is what we want to do. We all have the brains. We went to medical school, to nursing school, business school, whatever. But what separates out people who use biomarkers, you can't be lazy. You have to fit it together with everything else. But when we do, ladies and gentlemen, I can guarantee you that at the end of the day, the good history and the physical, and then adding the biomarkers like PenKid will lead to better care for our patients. I'll stop there. Thank you so much for your attention, and I'll turn it over to the moderator for questions.
Thank you so very much, Doctor, for your outstanding presentation. And thank you so much for the audience for your continuing use of the submission of questions. If you're just joining us today here, you are able to submit questions by selecting the green Q&A button by the lower left-hand corner of the presentation window. We're going to be actually sending out another poll right now to you that is going to be pushed out here. And then you would, if you would mind taking a moment to actually go ahead and answer those poll questions for us today. So, Doctor, we do have a couple of questions here that have been coming in. Here, question number one, is there a role for PenKid in CDK diagnosis monitoring and treatment?
Well, that's a, let me make sure I'm not on mute. Okay, I think that's an excellent question. It looks as if in some early data that there are some people, normally when I was training, you could basically plot one over the creatinine over time and come up with almost a straight line of deterioration of renal function. It now looks like PenKid, if you put that into an equation, a progressive of CKD, that if the PenKid in that setting is elevated, that curve for progression to renal replacement therapy and dialysis is steeper. We don't even know exactly why or what the stimulus for PenKid is in this setting. But it's something that obviously in the future we're going to look at very carefully, especially in diseases like diabetes and other comorbidities that go along with CKD, to see what we can come up with.
Hey, thank you so very much. I do appreciate that here. Is there a role for PenKid in CDK diagnosis monitoring and treatment here? It looks like we have that question here.
Well, I think that's probably the one that, Bobby, that I just answered. So let's go to a different one.
Thank you. Thank you so very much. I appreciate that, Doctor. Here, and we do have this question. What if a patient comes in and is elevated CREs, and the CREs are normal here? So, and I apologize here. What if the patient comes in and the PenKid is elevated and the CREs is normal? Would you just consider to be at risk for AKI or not at risk already based on the elevations?
Well, and I showed this in a couple slides, but from my way of looking at things, and the data suggests that if your PenKid is high, and especially I think if you see the PenKid rising in a couple hours, remember it comes a couple days before the creatinine, they are at very high risk for developing kidney injury. Someday you may base the diagnosis of kidney injury on PenKid. It just so happens creatinine is a gold standard of sorts. You know, in the old days, the gold standard for an MI was CKMB. And then we found out that early elevations of troponin were more sensitive and specific. So I think that the time will tell. But right now, a high PenKid and the creatinine normal tells you beware. And there's certain things when I beware, like for heart failure, I would hold off on the ACE inhibitor. I would make sure they don't get any renal toxic antibiotics. I would monitor fluid and diuretics very, very carefully.
Thank you so very much. And doctor, how does PenKid compare with NephroCheck?
Sure. Well, I think NephroCheck, the big difference, I mean, NephroCheck's a urine marker, PenKid's in the blood, and I think most of the focus today has really been looking at PenKid to just augment our current standards. Since, NephroCheck is not yet, although it's out there, not yet the current standard, it really hasn't been examined, although I am sure in the near future there will be comparative data between the two. And whenever you compare the data, one could be better than the other. Sometimes there's even a role for both blood and urine marker. So we'll have to see.
Thank you so very much. Are there PenKid assays ready to come in routine clinical practice?
One sec. I think I lost. Can you repeat that, please?
Oh, yeah, not a problem at all, doctor. Here, are there PenKid assays ready to come in routine clinical practice?
Well, as a matter of fact, you can already get PenKid over in Europe for clinical use. And I'll tell you, I've talked to these people doing some of these studies I showed you, the Albios, the Frog study. They've seen it. They've seen the results of their study. These guys are starting to order this clinically over there. Now, right now, it's a research tool in the United States for a while as things are being prepared. And there will be some major labs very soon announce that you will be able to order this from, for research purposes only to start with. But I expect in the not too distant future, this will be a clinically available test.
Thank you so very much. And do you use PenKid with Proenkephalin in monitoring your sepsis patients?
Can you repeat the question, Bobby, there?
Oh, yes, I do apologize on that. Yes, and do you use a PenKid with your facilitation in monitoring your sepsis patients?
Well, again, it's not available yet in the United States. But I think what I've been hearing from the people now using this in sepsis over in Europe where the kits are available is that you should use this to monitor patients. And I showed you in Dr. DeSoma's study in sepsis in the ED that a high PenKid level needs to be followed up because if it goes low, they're safe. If it's not, they do poorly. The same token, if a low PenKid gets worse during hospitalization, they do poorly. And this is just in my sweet spot as a biomarker person. I want a biomarker that not only gives me risk, but it allows me the chance to see a change based on what I do to the patient. Because I know I'll try something. If it doesn't work, you know what? I'm going to try something else. And then something else and something else. I'm not going to give up. It's grilling steak for me. I have more opportunities.
Thank you so very much. And is there more data coming available on the PenKid test in the U.S. population?
Oh, yes. That's a great question. And there are numerous studies that are just being finished up, and some are in line to be published quite soon. So even though we've had over 20,000 people study, you're going to see more and more U.S. data sets being published within the year of 2017 for sure.
Hey, thank you so very much, Doctor. And how does it perform with CDK as comorbidity? And then a follow-up question is, what is the status of the FDA trials and clearance for commercial sale in the U.S.?
Well, I think that, again, talking about the CKD, I think it definitely is going to, it's a kidney marker. You saw the fantastic correlation with creatinine, the inverse correlation with GFR, and the fact that if it's still high in CKD can make there be a steeper slope to progression for dialysis. I am not privy to the FDA strategy yet, but I know there have been talks and there have been plans for 510K. I don't know where all that sits yet, but I know the owners of this test are hopeful that in the not too distant future we will have this clinically available.
Thank you so very much. And do you see integrating this test into clinical practice, or how do you see this?
Well, first of all, if I didn't see that I could integrate this in clinical practice, I absolutely would not talk about this test. And because I get asked to talk about a lot of things. I need to talk about, do research with, and work with biomarkers that I will immediately integrate. So how would I integrate this? Well, first of all, right now, anybody comes to the emergency room with acute heart failure, I get a BNP, a troponin, an ST2, and procalcitonin. And that gives me a measure of wall stress, the propensity for fibrosis, myocardial necrosis, and also the possibility of presence of a concomitant bacterial infection. What I don't have is something to tell me which third of those patients are going to get kidney injury. A creatinine probably will not tell me that because it's an older biomarker. It's telling us more in the past 3 days than what we're seeing in the ED. So if you have a hit of the PenKid, let's say you have a high PenKid in that setting, and you have a high BNP, suggesting a lot of volume, you're going to need to give diuretics, and your troponin's high, so that high volume is stretching the heart and doing damage, and your PenKid's high, you're going to be very careful knowing you have to give a lot of diuretic to take care of anything else that could hurt the kidneys. So I would not, under any circumstance, keep the ACE inhibitor going for a day or two while I do this. I wouldn't go run to get any contrast CT scans. And if I thought that patient needed a cardiac catheterization because maybe as an MI causing it, I would be loath to do this unless it were an absolute emergency in the setting of a high PenKid when you have to give contrast agents. This could really shut the kidneys down. Now, you can make the same case in sepsis. You know how important it is because in sepsis, in the emergency room, gosh, with 50% mortality, if you do get AKI and you're thinking more about contrast, you're thinking more about pouring a lot of different antibiotics, you're not quite sure when they're hypotensive. Do you give vasopressors? Do you give fluid? I'm putting a Swan-Ganz and I'm lining that guy up. I'm going to be very careful with my fluids. Nobody's putting in contrast unless it's absolutely necessary, and I'm going to treat them vigorously. And then again, finally, the same, at least in my spectrum, acute myocardial infarction. I showed you the data. It's very prognostic. If there's a high risk for kidney injury and it's not a STEMI, do you need to take them to the cath lab that day? I mean, really? You know? And I wouldn't. I would tune things up, try to get that PenKid down, see what happens to the creatinine, and move ahead cautiously. So I answer that question enthusiastically by saying, I will integrate this test into my practice the day that I get it. And I'm jealous of my friends in Europe that are already doing this.
Thank you so very much, Doctor. And do you have any confidence on the NGAL's effectiveness as a biomarker?
Well, you know, NGAL is with both blood and the urine, and there's we just published, and you can go to the JACC article. I led a multi-center trial in heart failure with NGAL, blood and urine, and the results were not great, in part because creatinine sometimes actually rises in heart failure without kidney injury, just from afferent and efferent effects on the kidney. But in that study, the NGAL, while it was predictive, wasn't any better than creatinine. So there was a potential sweet spot of a negative predictive value of a low NGAL in the setting of people with CKD, and that needs to be explored more. I think the problem and what confused people is that they tried to bring this marker out in patients with sepsis, and there it's probably not as good because of the inflammation that is also present. So I know a couple companies have sort of stopped looking at the NGAL. I know that Biomarker, which is a good company, is sort of taking up the mantle for both the blood and the urine, and we'll have to see. But right now, it's not quite given us what we've wanted in a biomarker, and very few people who've had the opportunity to try this over the years are still using this.
Thank you. And is there a difference with the Pro and PenKid?
No. PenKid is really the other name for the Proenkephalin, which is the surrogate marker. So PenKid is sort of the branding for the Proenkephalin, which is the pro-neurohormonal marker for the Enkephalin, which is markedly expressed throughout the kidney but is very difficult to measure. This is a stable surrogate, but it's got the half-life short enough that you can see changes quickly when there's changes in the condition.
Well, thank you so very much. And have you looked at PenKid in other species besides humans?
Yes, I think I don't have all that data, and I haven't personally, but there are many animal models of kidney injury. Going way back to even enkephalin and opioid receptors I showed on the first slides. Many animal models where you really saw enkephalin expressed by receptors in the kidney and a little less in the heart. So I think all data, human data, needs to obviously be first shown in some animal models. And I don't know all the models offhand, but I know the results have been consistent, suggesting that there's a need with enkephalin associated with the need for the kidney to operate and perform normally and excrete what it needs to excrete. So I think that data is there for the looking.
Thank you so very much. And how is PenKid measured in your facility?
Well, so there's a chemiluminescence assay, but again, we are not measuring yet in my facility. There are kits available in Europe that are being used, and I suspect, I'm not sure what they're going to do with the FDA here. I am sure eventually, at some point, this will be made available so that it can be easily used as an ELISA assay or even potentially as a point-of-care assay.
Thank you so very much. You kind of alluded to this, but when is this going to be available in the U.S.?
Well, again, I don't really have a crystal ball on this one. I don't know. I think there have been discussions with the FDA, and that's sort of all we can say right now. And again, I'm not in the position to really be privy to that. I do know that very soon it will be available for research. And if I did have to look at my crystal ball, if you asked me 5 more times, I think probably a year. You know, the FDA has created problems for all sorts of biomarkers and biomarker companies, so that year has to have a great deal of variation on it at this point.
Well, thank you so very much. So we have a revised question here. If patients with CDK, how accurately does it predict AKI?
Well, I think that, remember I also said at the end that you don't use a biomarker by itself. So if you have somebody with CKD come in, and we see this all the time, and they come in with acute heart failure, and we're worried whether that creatinine is going to bump in that setting, a high PenKid and a rising PenKid in the first few hours would make me very suspicious that AKI is happening.
And can you use PenKid for tailoring aminogloside doses?
Well, I don't know the answer to that yet. It's I think this will be potentially one of the studies that will be done. There is precedent in certainly using biomarkers to guide antibiotics. For instance, in Switzerland, the ProHOS studies led by Biet Mueller have suggested using procalcitonin to guide how long you give antibiotics. Works well. You can cut it by a third how much antibiotics you use. With the peak and trough of aminoglycosides, and you're worried about those, I think it's a little bit of a stretch at this time, but I think a good solid research study would be beautiful, beautiful in this area.
Thank you so very much. And Doctor, thank you again for going through all these questions with us today. Do you have any final comments for today's audience?
Well, I think my final comment would be, first of all, thank you all very much for taking time. I know everybody's so busy these days, and I really appreciate it. And I'm really excited about this biomarker. I live in the kidney field as the kidney relates to the heart. And the fact that this PenKid is sort of given, I think not only expression of what's going on in the kidney, but the interaction. The acute cardio-renal interaction is going to be super important. This is still a space that is, low-hanging fruit of an unmet need. I need good biomarkers. This looks to be lining up as really the top of the heap for ones that we should go after, and I'm very excited. And I think we're actually having, stay tuned, and we're going to have another webinar November. I can't remember the exact date. I can look it up here while I look. But I think by that time, we're going to even have new data. And also we'll know which labs are running it. So if your friends or colleagues didn't come to this one, please come to the next one. It won't all be me. It'll be some kidney people and some ED people. And it should be fantastic. I believe it's now on November 9th. So it'll be updated from here. And if you want to come again, we'll have some more data. You get different perspective. I'll just be one of 3 speakers. But otherwise, tell your colleagues. If you're excited about this, tell your colleagues. The way we get biomarkers going is to get people excited. And it doesn't matter whether you're a kidney doctor, a heart doctor, a lab doctor, or industry that's trying to make therapeutic drugs to affect the kidney. Get excited about this, and let's let people circle the wagons around and expand the knowledge base that we have.
Thank you again, Dr. Maisel, for your outstanding presentation. And yes, I do want to remind the audience once again for that November the 9th date, where Dr. Maisel will be here with his full faculty with an upcoming webinar as well.
Hello?
I'd also like to, definitely here still, Doctor?
I'm fine.
Yeah, and I would also like to thank the audience as well again for your outstanding questions, and Sinotech for also making this webcast possible as well. Again, that November the 9th date, please mark it on your calendars. And today's webcast will be available for on-demand viewing through April of 2017. You'll receive an email from LabRoots alerting you when this webcast will be available for replay. And then we're going to invite you to forward that announcement to your colleagues who have missed today's live event. Until next time, goodbye.